Hi everyone, and welcome to a lecture on the basic of ultrasound physics. I decided that physics can be a bit tricky to understand, especially when you're just reading it from a textbook. So I went out of my way and put together a lecture that I have now recorded myself talking over. If at any point there's anything that you need further clarification on or that you're really still not understanding, don't hesitate to hop on Canvas and pop the question on a discussion board so that we can talk about it a bit further. By the end of this lecture, you are going to hopefully understand how basic ultrasound imaging works. You'll be able to explain how an ultrasound image is produced, and you'll want to be able to explain the following terms in regards to ultrasound, which is the frequency, period, wavelength, and attenuation. The two chapters, which I think would be really helpful for you to read through and will give you kind of a better understanding, is the first two chapters in Kremkow, the 8th edition. This textbook is available online. There are other resources that I use in this lecture, which are you'll see kind of at the end as my references. But these two will give you kind of that concrete foundational knowledge so that you can really follow along throughout the lecture. So let's talk about sound. Sound is nothing more than pressure variations that are traveling through a medium. So right now, as you can hear me speak, the medium that is propagating my sound, or the sound, is air. If you happen to find yourself in a vacuum and you brought your laptop and you were trying to listen to this lecture, you would find it really difficult and actually impossible because there wouldn't be a medium for the sound to travel through. Audible sound is sound that operates at a frequency between 20 to 20,000 hertz. Ultrasound is sound that operates at a frequency higher than 20,000 hertz. And diagnostic ultrasound is between 1 to 20 megahertz. So realistically, the only difference between audible sound and diagnostic ultrasound is the frequency at which it operates. Now, ultrasound works really similarly to a pulse echo technique that a bat would use. In this example, pretend that the bat is our ultrasound transducer and that little bug is the kidney. So what would happen is our ultrasound transducer would send in a pulse of sound, and that pulse of sound would travel through the body and it would eventually hit the kidney and then it would return back. After the ultrasound had sent in that first pulse, it would actually start timing to wait to see just how long it takes for that sound to return back. Once it returns back, our ultrasound machine can then calculate the distance where that structure is in the body. If something is closer to the skin surface, then it's going to be the echoes coming back are going to return faster than if it's really deep in our body. So right now we're going to talk about some of our sound parameters that I had mentioned earlier. The first one that we'll look at is frequency, which is the number of cycles that occur in a minute, and it's measured by hertz. The next one is period, and it is the time that it takes for one cycle to complete itself, and it is typically measured in seconds. The next one that we have is wavelength, and that is the length of space that one cycle takes up, which is usually measured in millimeters. And then finally, we have our propagation speed, which is the speed at which sound travels through a medium. If we take a look real quickly at these equations, you can see that most of these parameters are actually related to each other. So frequency and period have an inverse relationship with each other. And funny enough, frequency and wavelength also have an inverse relationship to each other. This is all going to become really important later on as we describe what happens when we pick a higher frequency transducer and what it does to our wavelength. And then we can look at that and see what happens to our images. So just for right now, I want you to take note of the fact that if I was to increase my frequency right here, and if my C value remained consistent or constant, my wavelength is going to get smaller. Or if I increase my wavelength and my C value stays constant, my frequency is going to decrease. Now, what I really want you to think about is actually just how the ultrasound transducer itself is built. So each transducer is built with thousands of tiny crystals. These crystals vibrate and send sound into our bodies. Once the transducer has sent out a pulse of sound, it's then going to wait and listen for those echoes to return before it sends out its next pulse. But the question is why? Why does diagnostic ultrasound need to be pulsed ultrasound? It is really important that you understand there is a difference between pulsed and continuous wave ultrasound. So why can we not have continuous waves? Well, if we had continuous wave ultrasound, our machines actually wouldn't be able to create an image. The ultrasound machine is capable of placing echoes appropriately on our screen or on our picture as a result of our really wonderful distance equals speed times time triangle that we would have learned in probably year 11 physics. So let's talk a little bit more about what happens. The ultrasound transducer is going to send out a pulse of sound. One pulse will make up one scan line of an image. If you look at any ultrasound image, it's usually made up of around 96 to 256 scan lines. So again, one pulse, one scan line. One image is going to be between 96 to 256 scan lines. So when that sound enters the body, it's going to encounter a bunch of different interfaces. And as it does that, it's going to be reflected back to the transducer. Once it comes back to the transducer, the ultrasound will then be able to calculate how deep that object was and place it appropriately on our screen. Once it gets that information back, it is then ready to send out the next pulse. If the ultrasound machine or transducer, was constantly sending out sound and had no listening period, when those echoes came back to the transducer, there would be no way for the crystals to know which pulse those echoes came back from. So I've even got a pretty little drawing here for you guys so that you can kind of see that. And you can see in this image of this really lovely left kidney. So again, if we're going to assume that this entire image is made up of, let's say, 200 scan lines, it means that one scan line was sent through here, and when the information got back, then another crystal would have sent out, or another bunch of crystals would have sent out another scan line to build this one as it slowly goes through this entire image to put together all of the information. What is incredible is just how quickly this happens. When you're actually scanning real time, there's very little lag. When you're scanning, it just seems like you're seeing everything all at the same time, when really these crystals and the machines are working so quickly to put together these frames for us. Now, as I had mentioned earlier, we kind of have our C value. And that C value is the propagation speed of sound through tissue. In ultrasound, it is assumed that the C value is constant and that it is always 1540 meters per second. That's 1,540 meters per second. Our machine has to actually assume that value so that it can make a calculation and place our echoes properly. As a result of this assumption, we also assume that it takes 13 microseconds for our ultrasound beam to travel 1 centimeter within the body. We've already talked about a few important terms, and of course there's going to be more. These terms are specific with pulsed ultrasound. So the first term that we're going to talk about is the pulse repetition frequency. The pulse repetition frequency is the number of pulses that occur in 1 second. Remember that frequency is the number of cycles per minute. So within each pulsed sound wave, there's going to be multiple cycles. In diagnostic ultrasound, there's usually a few thousand pulses per second, which means that the PRF is usually expressed in kilohertz. The pulse repetition period is the time from the beginning of one pulse to the next. The PRP and the PRF have an inverse relationship, the same way that frequency and period did. If the PRF, or the pulse repetition frequency, increases, it means that there's going to be more pulses per second. So it makes sense that if I have more pulses per second, the time between each pulse is going to be less. Therefore, an increase in my pulse repetition frequency means a decrease in my pulse repetition period. The pulse duration is the time that it takes for one pulse to occur. We can easily calculate our pulse duration if we know what our period is, or the time it takes for one cycle to be complete, and if we know how many cycles are in a pulse. All we would have to do is multiply those two numbers. Another really important factor that we talk about in sound is amplitude. And amplitude is the indicator of strength of sound. It's the maximum variation or vibration or movement that occurs in an acoustic variable. Intensity is the rate at which energy passes through a unit area. So we have power over area. So it's important to realize that if we decrease our area, our intensity is going to increase. And if we increase our area, our intensity is going to decrease. This is all going to become really important when we talk about image optimization. Now, attenuation is the weakening of sound as it propagates. As we've talked about, our ultrasound beam is going to be propagating through our body, which means that it is going to get attenuated and it is going to become weaker. Now, why does attenuation become relevant in ultrasound? Well, it becomes important for us to know and to understand because with attenuation, we get limited imaging depth. As the sound travels through any medium in the body, the amplitude and the intensity of the beam is going to decrease. And there are three main ways that this occurs. The first one is absorption. So remember, when we talk about absorption, we have to go back to physics, or very basic physics, which is that energy can never be created or destroyed, but it can be transferred. If we break down what sound energy is, it really is just a mechanical type of energy, and we have particles in our body that are vibrating or resonating at super high frequencies. As these particles are vibrating, the energy is being transferred from mechanical to thermal. The next way that sound can be attenuated is by reflection, and then by scattering of sound as it encounters different tissues. We'll talk a little bit more about that a little bit later on in the lecture. There we go. So the attenuation coefficient is the attenuation that occurs with each centimeter that sound travels. The further that sound travels, the greater the attenuation, which makes perfect sense. If we look at this table from Kremkow, table 2-4, that comes from the 8th edition, we can see that as frequency increases, the average attenuation coefficient for soft tissue also increases. Then if we look at the intensity reduction in a 1 centimeter path compared to a 10 centimeter path, we can see just how much greater the percent reduction is. That makes sense, right? As the sound wave has to travel deeper and deeper, we know that each centimeter it moves, it gets weaker and weaker. So of course, as we increase our path length, it would only make logical sense that the strength of our sound beam would also be weakening. So, as frequency increases, attenuation also increases. The more attenuation we have, the less penetration depth we can get. So if you're talking to a sonographer and you're asking them about what kind of transducer they're going to select for their exam, it often depends on where they're looking. If we're looking at a structure that's really superficial, let's say a thyroid, which is just in the neck, we don't really need that much penetration, which means that we can use a really high frequency transducer. We don't need to penetrate very deep. Versus if we're looking at someone's liver, which sits a lot deeper in someone's body, we're more likely going to need a lower frequency transducer so that we can fully penetrate and get all the way down to that posterior part of that liver. I had briefly mentioned that reflection is part of attenuation for ultrasound. And again, if we look at this diagram, I think it does a really great job at describing why that is. So as our sound comes in, we have our incident pulse right here, this light blue or maybe aqua-y type color arrow going down. And then it's going to hit an interface. Part of our sound is going to get reflected back. Well, the other part is going to get transmitted onwards and is going to continue to propagate through the body. Of course, because we have a portion of that sound going back towards our transducer, the transmitted pulse has already lost some energy. So again, contributing to that attenuation factor. Now, we are really starting to put together some of the fundamental concepts of ultrasound. The next thing that we need to try and talk about and understand is how on earth do we actually get an image? Well, we've already talked about how diagnostic ultrasound is pulsed ultrasound and how each image is made up of multiple scan lines. When a pulse of sound is sent into the body, that sound is actually going to encounter multiple interfaces. So once it hits an interface, it can either get reflected back to the transducer, it can get scattered in a different direction, or it can continue throughout the body. Now, I can really only imagine that everyone is dying to find out what exactly influences whether or not our sound beam gets reflected back to the transducer or whether it continues It's a really, really brilliant question, and I do actually have the answer for you, and it's the difference in acoustic impedance. So acoustic impedance is found by the density of a tissue multiplied by the propagation speed of sound through that tissue. So I want you to think about how the human body is actually made up of a whole bunch of different types of tissue. Let's just take a real quick let's take a quick look at an axial slice of the human body and talk about what types of tissue our ultrasound beam might encounter as it goes through the body. So if we're using an anterior approach, which is going to be somewhere around here, the first thing that our ultrasound beam is going to encounter is going to be our subcutaneous tissue. For the majority of people, subcutaneous tissue is going to be fat. So if we look at that Z value, it's about 1.33 times 10 to the 6. All good. So we have sound that goes into the body, and then the first thing it's going to encounter is, let's say, the liver. Now, the difference between the liver and fat is there's a difference. It's not huge, but there is a difference. So we're probably going to be getting some echoes getting sent back to our transducer, but we're also going to have quite a bit of that sound continuing through the liver. And it's going to keep going through and it's going to keep going through until it hits our next structure, which might be the descending aorta. So when it hits the descending aorta, it's important to remember that all of our blood vessels are encapsulated by this really nice fibrous sheath. So it might hit that sheath, and the difference, unfortunately, we don't have that value here, but it is fibrous tissue, which is going to be different than the liver, so we're probably going to get a bit of reflection back. And then we're going to have sound that continues through. The next thing that it's going to end up going through is going to be blood. And so blood, the Z difference, again, isn't massive. It's 1.67 to 1.66. So we'll probably have some echoes going back to the transducer, but still we're going to have more sound going through and continuing through the body. And then after it goes through the aorta, it's going to hit the spine. Now, the spine is made up of bone, and bone has a huge Z value. So then, when it encounters the bone, because of that massive change in Z, the majority, almost all of our sound is going to be reflected back to our transducer, and very little is actually going to be able to go through that bone. The other thing that happens with bone is that because it's so dense, it actually absorbs so much sound so quickly that even if some sound did get through, it wouldn't actually be able to be strong enough to get picked back up as it made its way back to the transducer. Now, when we look at the formula that we use to calculate impedance, you have to note that density, if the density of tissue increases, our Z value is also going to increase. And then if we have an increase in our C value, or the propagation speed, impedance is also going to increase. These are all available in your readings that are online, all of these charts, so I strongly recommend that you go through and find them and write them down because they are really, really helpful. So you can take a look at these two calculations to really help you wrap your head around how we can determine how much of our ultrasound beam is going to be reflected back to our transducer and how much is going to be transmitted into the body. And you can see that it is really dependent on the difference in those Z values. Again, take a look at this table. These are our Z values. Look at the difference in some of these Z values. For a lot of it, it's quite similar until we get to air and until we get to bone. So when you're looking at an ultrasound machine and someone says that someone is really gassy and they're a really technically difficult exam, it's because if our transducer or if our sound is interacting with air, a lot of that sound is going to get reflected back to our transducer and we can't see past it. It's also why ultrasound isn't a very good modality at looking at bone, because we don't get much information. All of our sound gets absorbed or reflected back. The first time that a lot of people look at an ultrasound, they think, oh my God, it looks like a whole bunch of gray blobs. And they're not wrong. I would be lying if I said at one point I didn't also think that ultrasound looked like a bunch of gray blobs. We have 256 shades of gray that make up an ultrasound image, or that could potentially make up an ultrasound image. It's really important that we understand that the different shades of gray represent the strength of the returning echo. The stronger the echo, the brighter or the more echogenic the echo is going to appear on ultrasound. And the weaker the echo, the darker or the more hypoechoic it's going to be on ultrasound. Now, there's definitely going to be things that influence just how strong an echo is when it comes back to our transducer. For example, how far did the echo have to travel to return back to the transducer? So how much was it already attenuated? And what was the acoustic impedance difference between the two boundaries and the tissue type? So in summary, our ultrasound machine transmits a high-frequency sound pulse into the body using a transducer. The sound will travel into the body and hit a boundary between two tissues. Some of the sound is going to get reflected back to the transducer, while some is going to go to the next boundary and then get reflected back. Reflected waves are detected by the transducer and relate to the machine, and the machine can then calculate the distance from the transducer to the tissue by using distance equals velocity over time. The machine will display the distance and the intensities of the echoes on the screen, forming a 2D image of a 3D structure. Other resources that I used in this lecture are right here. If you guys have any additional questions, you need further clarifications, like I said at the beginning of the lecture, please don't hesitate to post it on the discussion board where we can talk a little bit more. Cheers!